just a minute. Our next speaker is Dr. Gowri, who would be detailing us on how to read a visual field printout. Dr. Gowri is a consultant glaucoma services from Prabha Eye Clinic and Research Center and has had a special attribute of actually winning Best Paper Awards in 4 different years of the GSI conference. That's admirable. She has published articles in peer-reviewed journals, has been a reviewer of leading international journals, and has research interest in a variety of issues in ophthalmology. We are indeed indebted to you, Dr. Gowri, for being with us, and we look forward to hearing your talk.
Thanks, Dr. Chitra, for the kind introduction. So without much delay, I'll go on to my topic. So how do we read a visual field printout? So what we have to realize is what is being measured is the visual field, and we all know that it is all the space that the eye can see at any given instant. And what we essentially do is static perimetry, and it measures something known as threshold. The unit of measurement of this is decibel, and it represents the relative sensitivity of points on the island of vision. So more the decibel, lesser the light intensity which is projected, and higher the sensitivity of the retina. So when we choose a test, it is a combination of the strategy, which is either full threshold, CETA fast, etc. The program which is used, the area which is being tested, that is either 30-2, 24-2, 10-2, macular, etc. And the technique, which is either white on white or blue on yellow, etc. So it is a combination of all these 3. So let's go ahead and look at how we read a printout. It helps to have these region-based approaches. So the first zone is where you have the patient data, where the name of the patient, date of birth, the pupil diameter, visual acuity, and the refractive error should be entered. Encourage your perimetries to enter everything. Even the visual acuity should not be left unentered. The test data tells you what is the test which is being done and what is the strategy which is used, the stimulus size which is used, and the other factors such as the fixation monitor being used. So the age is important because the interpretation of the raw data by the StatPack is age dependent. Also, the size of the pupil automatically is measured by some Humphrey perimeters. Otherwise, you have to enter it. A constricted or a dilated pupil can give rise to certain, visual field defects which could be confused. So refractive error should be corrected for near vision, else it can lead on to generalized depression. So let's quickly look at this visual field and see what's wrong with it. If you can see here, the fixation losses are 18/18. So what is wrong with this patient? The blind spot is on the right side. This patient, they have actually entered the eye wrong as the left eye. So this patient, the perimetrist has made an error. The patient has done the test wonderfully. The blind spot is on the right side. But since the perimetrist you entered it as the left eye, it was always searching for the blind spot here. And therefore, you see the fixation losses are 18/18. So the next point that we have to look at is the reliability indices. This is this box over here, where you have the fixation losses, the false positives, and the false negative. So more than 20% of fixation losses is generally unreliable. How do we test this? By presenting the stimulus on the blind spot. False positives are when the patient pushes the response button even when the stimulus is not projected. For just the sound or in a periodicity, the patient keeps on pressing the response button. So again, greater than 33% is marked as unreliable. If the patient has lost his or her attention or has fallen off to sleep, then he does not respond even to the brightest stimulus. So this is what is captured as a false negative. And more than 33% again is unreliable. So let's look at this field. So here the fixation losses are marked as 7/17, and the field has been marked as low patient reliability. But if you look at the gaze tracking, see here, this is the infrared tracking which tracks the eye throughout the test. And you can see that the upward deflections which indicate eye movement are practically very, very small. So the patient has actually maintained his or her fixation, but then you are seeing that there is a fixation loss over here. So the disc is also quite okay and doesn't correlate. I mean, though there is an inferior this thing here, this defect does not correlate with anything that we see on the disc. Why does this happen? As the test is going on, the patient has started to tilt her head. So the blind spot moves. And so what was initially marked as the blind spot has now moved when the test is going on. And therefore, this is a pseudo fixation loss. So this is something that you need to understand. The patient's head should be central and straight. And this has to be looked at. A truly unreliable field will have high fixation losses, and the gaze tracking also will show a lot of deflections, and such a field is also marked here as low patient reliability. One should have extreme caution and should not preferably interpret such fields. So this is another printout where you can see that the first 4 points, usually the field starts testing at these 4 points first, 1, 2, 3, and 4. So the 4 points the patient has responded to a certain extent, and afterwards he or she has not responded at all. So you have all zeros, and you can see the false negative is almost 62%. So this is a white clover leaf, which indicates that the patient is fatigued or not able to understand how to do the test properly. This is the reverse of that. The same reason the 4 points are tested initially, the perimetrist has not explained how the test is going on. So initially the patient has not responded very well. He or she has learned on the test, and subsequently he has responded quite well. So you have these 4 points as black, and the rest are more or less okay. So this is the reverse. It is initial inattention or a black clover leaf. So the next region that we look at is the gray scale. So this we just need to view with defocus and look for general trends. So here I would say there is some defect in the superior nasal field which respects the horizontal meridian. That is the only information that I will look for. The fifth zone is the total deviation numerical plot. So if you look at the normal sensitivity and the patient's retinal sensitivity, and you look at the difference at each point, that is what gives you the total deviation numerical plot. So this tells you how defective the patient's field is when compared to the normal of the same age group. So this total deviation numerical probability plot has no meaning unless we convert it into probabilities. So that is what the total deviation probability plot does. So these are the p-values which are there with these symbols, and each of these numbers is converted into the probability points. So wherever you have this dark black square, that means that it is very highly likely that the patient's threshold is abnormal, that is p less than 0.5%, and the other symbols indicate these probabilities as shown here. Lower the p-value, the greater its clinical significance. The next zone is the pattern deviation numerical plot, and this what happens is in the total deviation numerical plot, the 7th best retinal sensitivity is converted to 0, and then this is added to all the points in the TDNP, and this is what gives you the pattern deviation probability plot, numerical plot, sorry. So this pattern deviation numerical plot forms the basis for the GHT test as well. So again, this numerical plot, we can't make too much sense out of the numbers. We have to rely on the pattern deviation probability plot, again, where we have these symbols, which will tell us how likely that this area of the visual field is abnormal. So after these two plots, we'll have to look at the raw data. We'll have to look at the suspicious areas which were indicated by the total deviation map. And you have to follow a standard geographic sequence. So the fixation, the fovea should have thresholds more than 36 or 37. Around the fovea, you have it in your 30s. And as you go into the periphery, you have the threshold in the 20s. So after these areas, we come to the statistical indices. So these are all the various statistical indices which are there. The short-term fluctuation and CPST used to be showed for the full threshold testing, and they are not shown for the CETA standard or the CETA fast testing. So each one of these will look at mean deviation. It represents the height of the hill of vision. It is the average of the overall severity of the visual field loss. So a negative value will indicate that the patient's overall sensitivity is worse than the normal individual by that many decibels. A positive value indicates that the patient's overall sensitivity is better than the normal individual. Here again, there is a p-value which will tell you the significance of the particular mean deviation value. So the pattern standard deviation, in contrast, is the index of irregular loss. So in the PD plot, what you saw is the generalized loss was removed, and the areas where there is localized depression, these are the ones which are shown. And this PSD index shows the departure from the normal slope of hill of vision. So higher the PSD, more localized the field loss. The next thing is the glaucoma field test. It compares mirror image locations of superior and inferior retina and gives 5 comments. GHT outside normal limits if the difference is greater than that found in 1% of the population, borderline low sensitive, abnormally high sensitive where there are more sensitive portions, usually in false positive cases, and GHT within normal limits when none of these above 4 conditions are met. There is an additional index called the visual field index. This is a global metric that represents the entire visual field as a single percentage based on normal. So 100% is a fully normal field and 0% is a fully abnormal field. And in between, it is the percentage that the patient's field falls into. So it's based largely on the pattern deviation and weighs central points more than the peripheral ones. The VFI helps us to look at the rate of change over time and helps us in calculating the rate of progression. So once we know that there is an abnormality, one needs to have certain criterion to say that this is definitely abnormal. The Anderson's criteria is one that is followed quite commonly, and this is what the Anderson's criteria is. You can refer and find out. But the most important thing is that it should be correlated clinically. So let's just look at a few visual fields and go through this systematic process of interpreting. So I will show you both the field and the disc picture to simulate a clinical scenario. So first what we do is patient data and test data. This is verified. The patient data has been entered and it's a 30-2 test with the CETA standard strategy. Reliability, we look at the reliability. It is quite reliable. Foveal sensitivity is next to be looked at. The foveal sensitivity is 31.5, 1 second. The fovea is turned on. It is 35 decibels, which correlates with the visual acuity, which is 6.9. And the acuity is correlating. Is the blind spot located correctly? See, when you have the blind spot, the point next to it should be 0. So most probably here the blind spot has been located correctly. The grayscale defects indicate a superior defect, which is going in an arcuate fashion and respecting the horizontal meridian. The total deviation probability plot shows some amount of depression in the superior hemifield, but the inferior hemifield is by and large normal, but there is no generalized depression. There is more of a localized depression, which is superior and has a respect for the horizontal meridian. Is the fixation involved? No. And what does the GHT say? It is outside normal limits. What do the global indices say? The mean deviation is very abnormal, minus 13.22, and the pattern standard deviation is also very abnormal. Both are at P less than 0.5%. Anderson's criterion, yes, it is fulfilled. There are more than 3 non-edge points which are abnormal, and most of them are at P less than 0.5%. Does it correlate with the disc? The most important question. So you have a superior defect and you have an inferior notch along with the inferior nerve fiber layer defect, and so it correlates with the disc, and therefore we can very confidently say that this patient has glaucoma, and this is a reliable field for a disc which we are seeing. Again, here you have this visual field and the you have this visual field and the disc. So here again, patient data and test data, they are verified. You have some amount of false negatives, but these are not very high. And the foveal sensitivity is 34, correlates with the visual acuity. Blind spot is located correctly here, and the lower point is 0. And grayscale, again, you have defects which are along the horizontal meridian, inferior nasally. In the TD plot, is there some amount of generalized loss? Yes, there is some loss over here also, but pattern deviation probability plot, there is a localized depression here, and it respects the horizontal meridian and is in the nasal field. So it is a nasal step. Is the fixation involved? No. And what does the GHT say? It is outside normal limits, and global indices are also abnormal, MD and PSD. Is the Anderson criteria fulfilled? Greater than 3 non-edge points abnormal in a clinically relevant area? Yes, it is fulfilled. Does the disc correlate with your visual fields? Yes, because here you are seeing some amount of superior rim loss, which is correlating with the inferior nasal visual field defect that you are seeing. So here again, this patient definitely has glaucoma, and this field is a proper one for a baseline field. So again, let us look at this particular example. Patient data and the test data, again CETA standard verified, and false negatives are slightly 11%, but still it is a reliable field. Foveal sensitivity is 35, correlates with 6/9. Blind spot is located correctly, it is here. So that is not a problem. The patient head has been, positioned correctly. Grayscale defects, there is some amount of defect here in the superior hemifield, but doesn't reach up to the horizontal meridian. Total deviation probability plot. So you can see that there is not much of a generalized loss, more of a localized loss, because the total deviation and pattern deviation plots are very similar. And this is in the superior hemifield, but does not come down to the horizontal meridian and does not widen as it is coming nasally. Is the fixation involved? No. GHT is outside normal limits, MD is abnormal, PST is also abnormal. Anderson's criteria is technically fulfilled, but look at the clinical criterion, which is correlation with the visual field, with the disc picture. So does this disc correlate with this field? The inferior rim is healthy. The isn't rule is followed. So no, it doesn't correlate with the visual field. So there must be something wrong. It needs further testing, or we need to look at this more detail. So this particular patient had ptosis, and once we did the lid taping, you can see that that superior defect largely disappears, and this field is showing only generalized loss, and the pattern deviation plot is by and large normal, which correlates with this disc that we are seeing here. So the next visual field, again, patient data verified, reliable test, foveal sensitivity correlates with visual acuity, blind spot is located correctly, grayscale defect shows a superior defect which is respecting the horizontal meridian. TD plot and PD plot are very similar, so there is only a localized depression in the superior hemifield. Is the fixation involved? Yes, it is very near fixation over here, because these 2 points are single digit numbers or 0. So this particular patient should preferably undergo a 10-2 testing to look at the central 10 degrees in more detail. GHT obviously will be outside normal limits, and MD and PST will be abnormal. Anderson's criteria is also fulfilled, and disc here, which shows inferior rim loss, correlates with the visual fields, and therefore again this is a field where glaucoma is definitely present. So these are just a few examples. Whenever you look at a visual field, look at whether there is an abnormality. Is this an artifact or a real abnormality? And next, ask you, is the abnormality consistent with the diagnosis of glaucoma? In that, the complete examination of the patient and correlating the field with the clinical findings is what is most important, because there are many scotoma traps in a perimetrist way. So there are a lot of defects which can mimic glaucoma. There are various diseases like neurological diseases, retinal artery or vein occlusions, which can mimic defects which are very similar to those found in glaucoma. There's no time to show all of those. So one should correlate with the clinical findings, and that is the most important thing to take home. Thank you very much.